Okay, welcome to today's session, which is Updates in Care. Let me go back a bit here. We are your moderators. I'm Lucy Wadsworth from the Manchester Adult Cystic Fibrosis Centre in the UK, and I've got Cameron Hamill, sorry I moved away from my mic, from UCLA as well with me, who is a PT. We have no disclosures between us. So you can find all this on the app as well, but these are just our aims and objectives for this session. But all today's sessions are posters as well. So there's obviously the poster session today where you can find all our amazing speakers as well and go and speak to them more if you have any questions, or if you're a little bit shy to ask any questions as well, you can find them downstairs in the basement. So here are our objectives as well. Today we've got hopefully something that will tickle everyone's taste buds, from RT to PT to a bit of audiology as well. So we're covering all bases here today. And I thought I'd just introduce all our speakers just to begin with, just to save a bit of time in between talks as well. So first up, we're going to have Lauren. And Lauren is a PT from the Children's Hospital of the King's Daughters Newport News in Virginia, and also works as a mentor. We'll have Sandy speaking to us as well, who is an adult CF respiratory therapy clinical coordinator in Omaha, Nebraska. I hope I'm saying all your American states and things right. We'll have Alison with us as well, who's a pediatric PT and CF lead therapist from the Primary Children's Hospital in Salt Lake City in Utah. We've got Angela with us as well, who is one of our audiologists, and she is from Oregon Health Science University. And then we'll finish with Lily, who, be kind to Lily, she's got a sore voice, so we're not going to make her shout too loud. But Lily is from Sutter Medical Center in Sacramento, California. And actually, interesting fact about Lily is she's very good with the Gen Z slang as well. I like that about your your bio. So on that note, we are going to run it up, and this session's going to be heat, aka we're going to have a good session for no Gen Zs in the crowd. And please just welcome our first speaker, who is Lauren.
Hi, good morning. I'm Lauren Mahoney, coming from the Children's Hospital of the King's Daughters in Norfolk, Virginia. Today, I am going to be presenting my abstract titled Tutorial Video Improves Huff Cough Quality in Patients with Cystic Fibrosis, using a novel measure to objectively assess technique. So I have no relationships to disclose. So as we all know, the huff cough is a vital part of cystic fibrosis care. When combined with airway clearance, it can be an incredibly effective way to clear mucus from the lungs. But the thing about the huff cough is that you need a specific technique and you need to practice it in a certain way in order for it to be effective. I loved in the talk yesterday about the agent, if anybody saw Daniela, and she spoke about how she did her CrossFit and she did her vest, and then she said, I finished that up with my huff cough. And I thought, proud moment there. So in our clinic, we noted that during the COVID pandemic, due to infection control protocols, we weren't able to practice the huff cough in clinic, largely due to masking. So we were asking patients largely subjectively, are you huff coughing? And of course you got the, okay, I'm huffing, yes. And we also missed out on that education, really demonstrating that for our younger patient population and those caregivers. So fast forward to relaxed protocols, and when we were able to have the patients actually demonstrate it for us, we got so many deer in the headlight looks. What is a huff cough? I'm not doing that. And there was a lot of confusion too, because patients without modulator therapy being a lot more dry thought they didn't need a huff cough anymore either. So we saw that there was this large education gap that we needed to address. So we decided that we needed to come up with a form of education where patients could practice huff coughing and then practice that technique though correctly and being able to practice it over and over again. So we kind of decided, I think a video could be a really great form of education in order to educate our patients on this technique. But we also saw that in doing this intervention, we needed some form of an objective measure in order to quantify the quality of the huff cough. So when we went to the literature, we realized there really was no way in order to objectively assess a patient's huff cough. So we knew that was another thing that we needed to create doing this project. So we collected our data from June 2024 to December 2024. We recruited patients in our pediatric clinic, ages 4 to 20 years old, and a single physical therapist performed all tests and measures. So within our clinic, we developed a short tutorial video on the proper huff cough technique, and we created a QR code so that patients could then view this video at home. We then created our own test and measure in order to assess the huff cough, and we created ours the Huff Cough Quality Index. If you ever need to name your own test and measure, it's not so easy trying to come up with a name. So here is the Huff Cough Quality Index. We called it the HCQI. It is a 5-item test. And with each item, the patient either gets a point for completing that or they get 0 points. So we broke the huff cough down in 5 very kind of black and white parts of the huff cough. So we assessed, did we see the patient take that nice diaphragmatic belly breath in? Did the patients hold their breath for 3 seconds prior to huffing? Did they keep their mouth in that really nice O shape? Did they exhale with control? We didn't want to see that forceful huff. We didn't want it to be too shallow. And then also, did the patient exhale all air out of their lungs? So with each huff cough trial, so we did 3 trials, and the patient, like I said before, got a point for completing it or not, and each huff got a total score. So let's say for huff cough trial 1, the patient got a 2 out of 5, then a 3 out of 5, and a 5 out of 5. This patient's score would have been 5 out of 5. We took the highest score out of the 3 trials. So for our methods, we had the patients come into clinic. There was no prior coaching or education. We just simply told the patient, huff cough 3 times, and we scored it using the HCQI. The patient then watched our huff cough tutorial video that lasted about 1.5 minutes. And then the patient huff coughed 3 times post-video per the HCQI. We then sent the patient home with a QR code to watch the video at home, and we put it on a sticker. We tried to make it very kid-friendly, having cartoon characters and such, and then we had some that would that our teenagers and our younger adults would like, and our idea was that you'd put this code on your vest, or you'd put it somewhere where you could see it while you're doing your airway clearance, and you could really watch this video. And then at 4 to 6 months at the patient's next visit, they then huff coughed again, no coaching. We just simply instructed the patient to huff cough. Again, with this time, based on the patient's compliance, maybe there were some illnesses in there. It was kind of a variable, but it was around 4 to 6 months after watching that initial video. I don't know that we have time to watch the video, but I will say there is a QR code on our poster, and I'll share that. One thing I did want to say about our video is that you'll see the patient does do some upper chest breathing in there, and I think that I would probably rate our patient a 4 out of 5, but if I have time, I'll try to come back and show you guys the video. Here is our huff cough video QR code. Oh, thanks, guys. So here are the results from our study. So this chart is showing our mean scores. And just to remind you, the maximum score they could have gotten on the HCQI was a score of 5. So before watching the video, our patients had an average score of 2.5. And again, the maximum score they could have gotten was 5. And I should say, we also had 44 patients who participated in this initial viewing of the video. And then immediately following watching the video, we had our score statistically was significant for an increase to 4.4. So that was a pretty nice jump. And again, the maximum score was 5. And then at that 4 to 6 month follow-up window, we had 29 patients who came back in. And while the score dropped to 3.8, it still stayed very nice. So just to orient you to this chart, this is just a spread of scores. So on my x-axis, we have the scores of the HCQI, 0 being the lowest and 5 being the highest. And on our y-axis, we have number of patients. So the darker blue is showing the spread of scores prior to watching the video. So you can see we had quite a few 0s, quite a few 2 and 3s, not many 5s at all. And then the light blue, oh no, don't look. I'm gonna spill the beans. The light blue is showing our patient scores after watching the video. So you can see that really nice score trend toward the 5, a lot of 3s and 4s. And the green is showing those follow-up scores. So we're sneaking in some 2s there, 3s, but overall a really nice trend and shift of scores towards that 5. So we thought we are awesome. Everybody went home. They watched their QR codes. Everybody's watching our video. We're going viral. Not so much. So to our surprise, only 4 patients out of 29 watched our video. I guess they were honest though. So in conclusion, I will say that the huff cough, what we can say is that our huff cough video did appear to improve patients' huff cough quality after one single viewing. The HCQI proved to be an effective tool, but I will say going forward, this is a measure that we need to validate, especially inter-tester reliability. If you remember, we only had one physical therapist that were performing all these tests and measures. We would have to see how it worked using multiple therapists. And also just looking at the sensitivity of the test. Is it sensitive enough in order to pick up on the huff cough changes? The compliance was pretty poor with the viewing of the video. But I think the thing that I keep thinking about in this study that I've probably taken the most away is that we want to educate our patients in the best way possible. So we chose the video in this study because we thought it would be a way for patients to go home and watch this, which didn't really happen. But it's gotten me thinking about how we can best educate our patients. Maybe it's not, the handout that we're constantly handing to the patients or us being the talking head. Maybe for this generation of pediatric patient, a screen is something that really appeals to them. The novelty, I'm a physical therapist, so we come into the room and we're saying, get ready for that, that step test. But on this day in particular, the patient was able to sit back and just watch a video. So I will say that I do feel like there's a place for the video. I'm still trying to mull over in, my head how we're going to use it. But again, we ultimately just want to educate our patients in the best way possible. So trying to continue to be novel with how we perform our education. So where we would like to go, I would love to create a video for our younger children, maybe with our original video has got a young adult, but maybe with a child, and to appeal more to a younger population. And maybe using some of those just techniques that we would use for the younger age group. Validate the HCQI, and again, just that thought about being innovative and how we're presenting education material. I think we would all probably put on a clown suit and perform a dance for our patients if they would just retain the education that we're giving them. So we just really want to find out how we can best educate our patients. So we do have a few minutes, so I will show you our video. Again, I will say, I was just talking about this with my coworker, Michelle, before showing you this video, and she's like, are you going to show it? I'm like, yeah. So the patient does do more of an upper chest breath, so we do notice that. So we probably would want the patient to do more of a diaphragmatic breath. So we've been talking about refilming our video. So again, I think I would probably give the patient a 4 out of 5.
Huff coughing is an efficient way of getting mucus out of your lungs, especially from deep in your lungs where mucus can settle in the lower parts. Huff coughing can be done in 4 easy steps. The first step is to take a big belly breath in. You can do this by putting your hand on your belly. As you take a breath in, you should see your hand move away from your body. Great. The second step is to hold your breath for 3 seconds. The third step is that you're going to keep your mouth in the shape of an O. If you have a hard time doing that, you can use the tubing to help keep your mouth in the O shape. The last step is to exhale like you're fogging up a mirror until all of the air is out of your lungs. Let's try. Now, to put it all together, number 1, you're going to take a belly breath in. 2, you're going to hold your breath for 3 seconds. 3, you're going to keep your mouth in the shape of an O. And 4, you're going to exhale all of the air out of your lungs like you're fogging up a mirror. Good.
Awesome. So we did use tubing in our video. If anybody hasn't tried that, it's a great way to keep that O shape in their mouth. So I am all done. Thank you guys so much. Oh, hold on here. Let me. Well, we are poster. Oh, here we go. Okay. So thank you guys so much. We're poster 494. We'll be at our poster from 1:15 to 2:15. So feel free to come by and chat. And if anybody has any research and they know how to validate a study, we could use all the help. So
Thank you.
thank you. Any questions?
You took my job away then. I'm here for one thing.
They would like you to put the QR code again.
Oh, yes, yes, yes.
If anyone does have any questions, please come to the microphone. There's also lots of seats at the front, so if you do want a seat, come on in, or shuffle up so people can get in.
Thank you for the talk. I have a comment and a question. So the comment is, I actually found your video online. My son is 9, he has CF. We're trying to teach him how to puff cough properly because there's so many different ways to do it. And so I actually used your video. We now use the little white tube, and it's really been helpful. So kudos to
Awesome. Thank you. Thank you. Thank you. I think we've got like 50,000 views. So in my mind, I'm like, we are totally viral.
probably 10 of those because
Yes.
we got to make sure we get it right. But my question is there any like potential for damage if you do the huff cough wrong? So in terms of like irritating the larynx or whatever that might be, any
I would
comments there?
say there's not so much of doing it. Like, let's say that you were to go too forcefully, you're just closing off the airway and you might not have it so open in order to get the secretions up. So by doing these specific steps, you're just more keeping the airway in an open position so that you can really get those secretions up and out. So I would say you're not going to hurt yourself. You just, we talked about like that effectiveness of the technique. It's more effective if you do it that way. Because you would think that, oh man, if I just really push this air out, I'm going to get this phlegm across the room, but it doesn't really work that way. You want to keep that nice, open, controlled exhale.
Thank you.
Yeah.
Hi,
Hi.
Kathy from the University of Michigan. I was curious if you guys do any sort of learning assessment prior, or if you included that in these 44 patients. Were there people with language barriers or reading disabilities or anything like that?
That is an excellent question. We did not. I will say that this wasn't a formal part of the study. I think just us knowing the patients. So if there was like a learning disability or we knew that cognitively that this wouldn't have been appropriate, we did not select those patients for our study. That would have been a good thing to have noted. And the same thing, I think we are a very small clinic. So I would say that there was really no language barriers that we have, but that's an excellent point. Thank you.
Lauren, we have a question on the iPad for you. Were you able to ask patients why they didn't watch the video?
Ooh, good question. I did not. So I'll have to follow up on that one. I'm guessing the sticker got put in the trash can.
Hi, Julie from Sanford Children's. How many times do you have them do the huff coughing? Do they move mucus, or do you just do so many coughs and be done?
Yeah, I mean, I would say, that's kind of taking this a step further. Ideally, we would be doing more education on, how we're going to use this huff cough, whether we're getting into parts of active cycle of breathing or doing something along those lines. I think we just felt like we were so low in our clinic at this point where nobody was even huff coughing. We just wanted patients to just huff cough. Please, if you're doing your best, if you will just huff cough even once, that's great. And I think our hope was that if the patient could be doing it in the right way, that it would be more effective and they could see that they were moving mucus and they were able to expel it. And therefore, hey, I'm going to keep doing this. I think that was my hope. That's a great point too, because just because they have great technique, if they're not doing it, then, what's the point? So that might be another part of the study too, where, you got great technique, but if you're throwing away your huff cough sticker, are you doing it at home? So that could have been a great question for us to ask too. Despite not watching the video, did you huff cough?
Just wondering, when I teach patients and they say, how many do I need to do?
Usually I would err on the side when you feel those secretions in your upper airways and then you can get into like autogenic drainage and all of that. But basically when those secretions are in your upper airways and you're huffing, you want to huff until you get those secretions out, bearing any sort of just being exhausted. If there's exhaustion and they just feel like they can't, it's a very exhausting maneuver. And even them doing those 3 trials of huff coughing, that is hard. So I would say, you kind of got to play with it. It's very individual for the patient.
Thank you.
Uh-huh.
Lauren, can I ask you a question? In this, you had a single therapist do all the tests. Do you think you would have had more variability if you'd had multiple therapists do it and different on your results? Or is that going to be part of your validation? Part
of our validation, definitely. So it's just testing that inter-tester reliability, trying to see how it would go if we had multiple people doing it. Mm-hmm.
And despite all the resources, why do you think we all do it slightly differently?
Ooh, it's a hard technique. It is. It is. And I do believe that I think that with a lot of our patients who are older and they've been doing the huff cough for a while, specifically those who use that as their form of airway clearance, I think that they just have a certain way, even if it's not beautiful, but it works for them. So you can't really take that away too.
We've got time for one more question.
I'm Jordan. I'm a nurse from Michigan. I have a question. I am wondering, do you have any tips for the nurses in getting our patients to huff before throat culture?
Oh, so if your goal, I would say, would be to try to get like a sputum sample. Like what we always say is let the physical therapist come in first if you have a PT at your clinic, and we usually will do like a step test with them. And then I don't know, it could just be me, but I love getting a sputum cup and being like, let me get that sample. Like I feel real proud. So I'll usually have the physical therapist come in. That's what we do at our clinic, try to mobilize those secretions and then do that huff in order to get it out. If you don't have a physical therapist available, even just trying to jump, if they use any SORM, just get them moving, unless they want to use, or any form of airway clearance that they usually do.
Okay.
Would be helpful, yeah.
Thank you.
Because if you ultimately want to mobilize, you can't use the huff on its own. You need to mobilize those secretions first, get them to the upper airway, and then that huff is able to get the secretions out.
Brill, thank you very much. There are a few more questions, but 494 is your poster?
494,
So
yes.
please find Lauren at lunchtime. Thank you so much.
Thank you, guys. Thank you.
Sandy. So,
Brill. So next up, we've got Sandy. So please welcome Sandy to the stage.
Good morning. Happy RT week and a happy PT month to everybody out there. So I'm going to talk about oxygen supplementation in pregnancy with cystic fibrosis. I have no disclaimers. Okay, so what prompted oxygenation evaluation in our pregnant CF population? Historically, pre-highly effective modulator therapy outcomes for pregnant patient mothers with CF were not great. Our CF director didn't like all the gray hairs our pregnant mothers with CF were giving him, and he had more than one tough experience over the years with our pregnant mothers with CF. Our CF physicians wondered if patients' oxygenation during pregnancy could be contributed to these less than desirable outcomes. Anytime our pregnant CF mothers were on our labor and delivery floor for an exacerbation and their oxygen saturation was less than 95%, they were placed on oxygen. This surprised us, so a conversation between our CF director and our high-risk OB took place. Then our center director came to two very inexperienced CF respiratory therapists to help figure out a way to assess for the need for oxygen during pregnancy and hopefully get insurance to pay for it. So please keep in mind, this is just what we decided to do at our CF center and are only reporting on this experience. So the problem was our high-risk OB team wanted our pregnant patients' oxygen saturation to be 95% or more, but insurance won't pay for supplemental oxygen until the patient's oxygen saturation is 88% or less at a chronic stable state at rest, with activity, or overnight for 5 minutes. We ultimately developed a plan to compromise and try to find a way to get insurance to pay for oxygen at 92% or less. So this is what our team came up with and what we decided to try to accomplish as a team. There was a lot of trial and error figuring out what process we could use and how to get insurance to pay for supplemental oxygen and the testing required to qualify for oxygen. So in assessing for our pregnant CF patients' oxygen levels, if they were stable from a respiratory standpoint, we did a spot check with spirometry, which was every 3 months, 6-minute walks, and overnight oximetry tests during the 2nd and the 3rd trimesters. If the patient was sick, we would treat or hospitalize the patient prior to trying to get qualifying oxygen. So why didn't we do qualifying testing during the 1st trimester? Well, quite frankly, a lot of the times we missed it. We weren't aware the patient was pregnant, and when we saw them in clinic, or we found out they were expecting after we saw them in clinic for that trimester. If we did find out they were pregnant, getting testing ordered and completed in a short time frame would be very difficult, And getting test results or potentially getting billed for a test can be emotionally devastating if the pregnancy was not viable. So after much trial and error, this was the process we came up with. Testing normally starts during the second trimester unless the patient's FEV1 was 50% or was less than 50%, or they required oxygen with a prior pregnancy. Then we would attempt to get testing during the first trimester. If we did end up starting a patient on nocturnal oxygen, we repeated an overnight oximetry test to make sure the patient has enough oxygen ordered, and once they are set up, and then every subsequent trimester. We also repeated a room air overnight oximetry test after pregnancy to make sure this patient didn't qualify. To make sure the patient doesn't qualify. I am so sorry. I am totally here. There. We also repeated a room air overnight oximetry test after pregnancy to make sure the patient truly doesn't need oxygen with traditional guidelines before discontinuing this. As you can see, there are a lot of steps in this process, and the process was modified several times, but once our team got used to it, things ran fairly smoothly. So some of the challenges we encountered while using the modified oxygen assessment protocol. Sometimes we didn't find out about the pregnancy well into the second trimester. Patients didn't do the testing as asked or do it in a timely fashion. We had a global pandemic in which patients were not coming into clinic. There was confusion with the process in the beginning as it was a lot of trial and error, and not all overnight oximetry tests report the same information. We needed specific data from the overnight oximetry test to calculate how much time a patient's oxygen saturation was 92% or less. We needed the length of the test and the SpO2% times chart. This requires a detailed report, not just the summary page from the overnight oximetry test, which most of us get faxed. We found a couple durable medical equipment companies that used a third-party provider that could provide us with correct information. However, it can be very difficult in rural areas to find companies to provide these reports, and not all overnight oximetry tests report oxygen desaturation index. And this isn't necessary, but it was an interesting finding on some of our more recent tests. Oxygen desaturation index is how often oxygen saturation drops by 3 to 4% from baseline and can signify sleep disorders. So this is a patient example. On the SpO2 data, you can see the patient had 0 minutes at 88% or less, but had 8.1 minutes at 89% or less. So she was very close to qualifying in the traditional guidelines. We technically didn't need to calculate anything since we were already showed that she was more than 5 minutes at 92% or less. But for example's sake, if you calculate how much time this patient spent at 92% or less, it was 22% of total testing time. The test ran over 9 hours and 2 minutes, or 542 minutes, and the patient spent 22% of this time at 92% or less, so 119 minutes. She was 92% or less. This is just one example of how we gathered our data. So what happens when it looks like our patient qualifies for nocturnal oxygen? Well, we have our physician review the overnight test to determine if all the data is viable. We let the patient know they qualified for oxygen at night with pregnancy per our guidelines and ask where they would like the order sent. We prepare and send the order. We make sure the duration on the order is in months or the remaining length of the pregnancy. We did not order oxygen for 99 months or a lifetime. Insurance is most likely to approve oxygen for a short period of time rather than a lifetime. And then we prepared a carefully crafted letter of medical necessity to submit with the order. So I apologize. This is hard to read. So I'll summarize what we've included in our letter of medical necessity. We include CF diagnosis with relevant testing such as PFTs that have perhaps declined in the last number of years. We discuss the results of the overnight oximetry test and state that this typically doesn't qualify for nocturnal oxygen. However, there are many factors affecting the respiratory system during pregnancy. Oxygen consumption starts to increase during the first trimester and continues throughout pregnancy, and it can increase up to 21% by term gestation due to fetal demands and increased maternal metabolic processes. Ventilatory augmentation does not make up for this demand, and the reduction of functional residual capacity combined with the increase in oxygen consumption lowers the oxygen reserve of the mother. Then we state the guidelines for our high-risk OB recommends keeping the mother's oxygen at 95% or higher to ensure that no harm comes to mother or the baby. So far, we have been successful in getting insurance to pay for some oxygen for the remainder of their pregnancy. So the demographics of our patients, over the 5 years, we did a retrospective look at this. So January 1st, 2019 to December 31st, 2024, we had 30 patients that accounted for 38 pregnancies. 7 patients had 2 pregnancies during this time, and 1 patient had 3 of these pregnancies. This particular mother needed oxygen with all 3 pregnancies, but only 2 of her pregnancies qualified at 88% or less. The ages of our CF pregnant mothers were 17 to 38 years old, and there were 3 sets of twins included in this data. So what did we find after going through this process for 5 years? We had no pregnant mothers that qualified for oxygen at rest or with activity. However, we did have patients qualify for nocturnal oxygen in our pregnancies. On the left, the bar shows the total number of pregnancies for our CF center in red. The gray on that bar shows all the women that qualified for nocturnal oxygen at 92% or less, including those that qualified at the traditional 88% or less guidelines. So 16 of 38 pregnancies, or 42%, had oxygen ordered at the 92% or less threshold. The right bar graph shows all of our pregnant patients in red again, but in gray are all the patients that qualified for oxygen with normal qualifications of 88% or less for 5 minutes. So 5 of 38 pregnancies, or 13%, qualified for oxygen without our new protocol. This shows that doing overnight oximetry during testing during pregnancy can be beneficial. So surely, these patients that qualified for oxygen at night have poor lung function, right? Well, not really. This bar graph shows the range of FEV1 of all of our patients at the time they qualified for oxygen at night. The red bars show the number of patients in each FEV1 range that qualify for nocturnal oxygen with our modified 92% protocol, and the patients with the gray bars qualified with the normal SpO2 of 88% threshold. As you can see, the patients that qualified for nocturnal oxygen do not have awful lung function. Our patients that qualified at 92% or less had a mean FEV1 of 85.4%, and the patients that qualified at the 88% threshold had a mean FEV1 of 81.8%. So what trimester did our CF pregnant mothers require oxygen? We had 1 patient qualify during the first trimester, 6 qualified during the second trimester, and 9 qualified during the third trimester. The patient that ended up qualifying during the first trimester is still on oxygen post-delivery. You might also be wondering if the 16 patients that qualified for oxygen at night were on highly effective modulator therapy. This slide shows 11 of the 16 were on highly effective modulator therapy the entire pregnancy. 2 patients were started on highly effective modulator therapy during pregnancy, and we had 1 mother with the 3 pregnancies that all needed oxygen that was not eligible for highly effective modulator therapy at all. You may also be wondering when our patients that required oxygen at night delivered their babies. This graph shows when all of our CF pregnant mothers at our center delivered. The gray bars show mothers that did not have supplemental oxygen, and the red bars are our patients that qualified for nocturnal oxygen. Our mom on oxygen that delivered at 34 weeks was positive for COVID during the first summer of the pandemic, which was most likely the reason for preterm delivery. So what did 5 years of working on this protocol teach us? Well, lung function is not necessarily predictive of who will need oxygen with pregnancy with or without our modified oxygen protocol. Patients with normal lung function may need oxygen with pregnancy utilizing a traditional 88% or less guideline. None of our patients qualified for oxygen at rest or with activity during this 5-year time frame. We did have 1 patient in the past that didn't need it, but that was prior to this time frame. Being on highly effective modulator therapy doesn't exclude the need for oxygen with pregnancy. Patients may need nocturnal oxygen at various stages of pregnancy. Having twins doesn't necessarily increase the chance of needing oxygen with pregnancy, as we had 3 sets of twins during this time and none of those mothers needed oxygen. Some of our patients that qualified for oxygen with pregnancy had a higher oxygen desaturation index, which mostly resolved with some supplemental oxygen during pregnancy. Normally, an ODI of 5 to 15 could possibly signify further sleep testing to be ordered. And that is something we wouldn't be able to get in that short a period of time frame during pregnancy. But post-pregnancy, all the women with the high ODIs that needed oxygen returned to a normal amount of ODIs post-delivery. Pregnant women can have sleep issues that needed addressed before pregnancy. Our patient that needed oxygen during the first trimester later got diagnosed with airway resistance syndrome on a polysomnogram and is still wearing 1 liter of oxygen since she doesn't qualify for CPAP. And fortunately, we didn't have any women that were in respiratory failure, so having an elevated CO2 level was not a concern for adding oxygen. Once again, this was just our experience I am sharing and how our CF team decided to assess for oxygen with pregnancy. While using our modified oxygen assessment protocol was valuable at our center, it also raised more questions. Thanks for bearing with me.
Thank you so much. Has anyone got any questions? At Manchester, we don't do this routinely, sort of screening our CF adult women, but you may be making me think that we maybe should look at it.
It's certainly nothing that we ever had done prior to this before. It was all kind of trial and error that started this. So.
And do you think the 92% of saturations, is that more benefit for mum or the fetus or both?
I would say primarily mother, because she has the reduced oxygen reserve. You know, babies have that increased higher fetal hemoglobin, so it's not so much for baby, but if mom gets stressed, then there's a chance of preterm delivery.
Well, please go ahead.
Hi, I was wondering if you looked at sputum colonization or anything with these mothers who were on oxygen versus not.
You know, that isn't something that we looked at. It's definitely something we could go back and look at pretty easily. We have a nice CF database that just shows everything that the patient's grown. So yeah, that's something we could really include in the data moving forward. Thank you.
I loved your talk. It was fantastic.
Thank you.
This actually made me think about, I had an inpatient a couple months ago, that same situation where they had her on oxygen and I was confused because I was like, she's at like 92, 93 at rest. I don't think she needs it. And I actually talked to the nursing staff and the team. They're like, no, we're trying to keep her up higher. And they also thought it was for the baby's purposes too. I don't, but it was definitely like, for me, I was like, we all don't want anyone on oxygen if they don't need it.
Exactly.
So I thought it was interesting. And then do you mind pulling up the letter again?
Of course.
Thank you.
I did attach that and the algorithm. If you go into the app, there is an attachment for it.
I have another question. Out of it, you might not know, but what was the weight of like the mothers or then the weight of the babies afterwards? Just thinking about sort of size of abdomen, impact on lung bases. Was there quite a variability in sort of mother's weight?
I will say, because we started this before our ETI came out, some of them got placed on ETI. 2 of them were placed on ETI during pregnancy. Over the course of the 5 years, it was interesting because the mothers at the beginning of the study tended to be lighter weight, of course. And then as we approached the 5-year mark, that is when their baseline weight was up. And then we also started noticing higher oxygen desaturation indexes as their weight was up. So please go ahead.
Hi, Jessie from Rainbows. I just had a question, actually. We were same patient that she was discussing. We had a lot of pushback, more so from the OB side, because we were like, no, 93 is great. And they were like, absolutely not. So I guess, how would you address that? Or did you have an issue with that?
So we were confused, like what's going on here? Every time I walk in this room, the patient's on oxygen. And so what ended up happening is we had our center director have partner with our high-risk OB team, and they had a discussion as to why, which I was not privy to. But she said that high risk OB, they always want their patients 95% or higher, which I always kind of questioned until one of our moms delivered at a different hospital. And that high risk OB, you know, we had told him, yeah, we're going to add oxygen for 92% or less. He goes, nope, I want it 95. I want her 95% or higher. And we also had another OB then deliver one of our babies because we were getting ready to start her on oxygen. So he just opted to deliver her instead.
My follow-up question is, if you had a patient that was placed on oxygen to keep them 95%, how are they discharging with?
So this is at home. Yeah.
Oh, okay.
Yeah, we do the overnight oximetry testing at home. That's actually overnight oximetry testing was something that made us start looking at it because when the patient was inpatient, we would try to get a test done and we're like, why are they putting that patient on oxygen all the time? So it actually added to the situation.
Thank you.
Do you know any data for mothers without CF for their overnight oxygen saturation?
That is one of the questions I have as well, because I don't know about any others of you out here that have had babies, but I was not that cute little pregnant mama. Everything was bigger on me when I was pregnant. And so I also too wonder if it's just CF moms or is it all of us?
Any more questions? If not, you are free to go.
All right, I'll be at poster 503 if you have more questions.
Also, if anyone's still looking for a seat, there's still plenty at the front, so please come on down while our next speaker's getting ready. But please welcome Alison. Oh, no, Alice, no. You've all changed.
I am Maddie McRoberts. I am a dietitian at Primary Children's with Allison, and we decided to tag team it today.
Perfect, tag team.
Let's see. Start.
Oh, you know what? Do you have my files? Do you go to my files, right? Just
Do you start
on my file?
Yeah.
Oh, just
This
Yeah,
one?
to start.
Oh,
Yeah.
that's what I brought up last time.
And then just make it big. Okay, there.
Perfect. Just get out of that. Awesome. Hey, hi everyone. Like I said, me and Allison are going to tag team it today, and we are going to talk on a virtual program we created called GOAT for our CF kids ages 8 through 12 years old. So this work was funded by a grant from Primary Children's Foundation. And then our team for our GOAT program consisted of social workers, Allison, our physical therapist, dietitians, and then parent partners. So these are our objectives for today. Today we're going to go through our program details and then also how you could implement something similar in your CF center. So for a little bit of a background, we created a multidisciplinary QI subgroup to address multiple areas of health, and we utilized the formal QI processes. We identified goals for improvement among our patient population, and this included health literacy, treatment adherence and compliance, and building healthy habits. We also identified an age group that we felt like would benefit from additional resources and education outside of clinic. And then we identified that age group being ages 8 through 12 years old. As a team, we created this barriers fishbone that focused on barriers to optimizing health in children with CF ages 7 to 14. So using that fishbone, we created a multidisciplinary team-led virtual education program. This program focused on independence and healthy lifestyle choices, interaction with other kids with CF, getting to know the care team outside of clinic, empowering children with CF to care for their mental, nutritional, and physical health, improving health literacy, engagement with CF cares, and also to help the kids identify fun and engaging ways to focus on their health both at home and in clinic. We did a literature review. On health literacy resources among children, and our aim was to improve health literacy with our participants. And then we used this literature review to help guide our lessons. So in our clinic, we love our acronyms and our puns. So we all know the typical GOAT, but what do we use GOAT to stand for in our clinic is great outcomes achieved together. We have our cute little goat. So for our program purpose, we created a global aim and a specific aim. So our global aim was to increase quality of life among our school-aged children with CF by creating engaging activities and providing education that promotes healthy lifestyle choices in their daily activities. This will also enhance connection between the CF team and the children, as well as peer connection among children with CF. And then for a specific aim, we did the Optimizing Health QI group. We'll utilize a customized measuring tool to assess quality of life pre- and post-educational group sessions. And by the last session of the program, scores from the pre- and post-survey will increase by 10%. Here's a brief project timeline for our creation of our program. I put this in here just to point out the importance of timelines and tasks when you're creating programs like this. So a little bit more about our program. So far, we've completed 2 cohorts of participants for our GOAT program. The first was in spring of 2024, and the second was in the fall of 2024. Both of our cohorts had 15 participants each. Our first cohort was ages 8 to 12 years old, and then after some feedback, we decided to tighten our age group to ages 10 to 12 years old. Each of our classes was 45 to 60 minutes, and there were 4 classes per cohort. The classes focused on a variety of topics, including CF as my superpower, loving your body, taking charge of my CF, and exercise and airway clearance. These topics were voted on by our participants and also were selected to help achieve our program goals. We also had additional guest appearances from some of our clinic team, such as our pharmacist coming in and talking about medication adherence with our kids. And then our participants completed pre- and post surveys. So here is a little bit of our survey results. In our survey, we asked 2 nutrition questions, 2 mental health questions, and 2 physical therapy questions that you can see on the slide. So with those survey results, we had in the first cohort a mean improvement score of 11.8% improvement, and 72.7% of our participants said they would like to participate and go again. And then in our second cohort, we had a mean improvement score of 15.2%, and 71% said they would like to participate again. And then we also were able to meet our specific aim of increasing scores by at least 10%, and 100% of our participants said we should continue doing programs like this in clinic. For our subjective data, we have some feedback from our patients and our parents, so I'll give you guys a second to read some of the fun quotes that we have. One that I really like is the one that says, "I liked knowing I'm not the only CF kid in the world." One of our big aims was to create this peer-to-peer connection with our kids, and so seeing that we were able to achieve that was great to see. And here are some of our fun pictures of us doing our program. And we'll let Allison finish the rest.
All right, so did we goat your attention yet? We wouldn't be PEDS providers without a pun or two, right? So now we're going to move on to the section about implementing a program like this at your own CF center. So one of the most important parts of our program was that we had a parent partner involved. They attended bi-monthly planning meetings. They've been able to provide us great feedback regarding program development, specifically like extracurricular activity conflicts, just really guiding our course content to make it age appropriate and kind of really just incorporate some great just health literacy kind of deficits that they've experienced with their own kids. And then also just really acknowledging and being mindful of treatment burnout. For the 2 parent partners that we have had, they've also had children in that selected age range. They've really been able to provide specific insight into that age group and its unique needs. All right, so looking at budgeting. So prior to creating the program and getting funding from our center, grants like specifically at our center, we had to come up with our budget. And so initially we tried to keep it to $50 per participant. This is just a nice little picture of what was included. They got a stress ball, they got an oil crayon, they got a CF coloring book, they got a really nice little feelings wheel, they got a gift card that covered the cost of materials for the cooking demo that Maddie previously mentioned. They got some hand sanitizer, a little My Plate that it was like plastic, but they could use it, just wasn't dishwasher safe. And then they got a jump rope, their little goat stuffed animal, or little mascot, and then lots of printed handouts that they used in each of our lessons. All right, so kind of moving on to funding and sustainability. We worked with our administration and specifically the medical director over our CF program in the Pulm department to approve this project. And we presented our proposed budget following the second cohort in terms of looking at future sessions and sustainability. We looked at the pre and post test data and we were able to present that to demonstrate the efficacy of the program. And we're not afraid to admit we were really thrifty. We utilized clinic resources, we used printed handouts, we were able to kind of spend a lot of time during and outside of clinic, and really try to deliver materials in clinic as much as possible to cut shipping costs down. Just a little bit about our center specifically. So we serve kind of the 6 surrounding states. So we serve Utah, Idaho, Wyoming, Montana. The majority of our participants were in Utah, so sometimes we were able to coordinate a local drop-off. And really kind of the biggest expense was staffing hours. We have been very lucky and allowed autonomy with our QA groups programming, but just kind of thinking about any multidisciplinary project like this, right? Like making sure that it's the best use of time and resources. All right, and just kind of some conclusions. In our personal experience, we had a ton of support from our CF team, which was really encouraging, and it was really cool to see other providers not on our QI team just really pump up this program, talk about how great it was, and really kind of help us with enrollment. There was a lot of interest and engaged family participation. We've got some parents in the audience supporting us, and their kids were a part of the program, and I think just having that, really having parents focus on the importance of programs like this and that connection at this age group was really cool. And then it was also great because we have had PEP training and a lot of QI training for our team. And so it was really nice to get to utilize all of the QI tools like Fishbone. Some limitations that we noted, we did have some technical malfunctions with our HIPAA secure platform. So we used Microsoft Teams and had tried to do some breakout rooms and had kind of some difficulty with people getting back to it. So I think for many of us, kind of those pieces can be a barrier. Time restraints were also definitely difficult. We tried to keep our sessions to 45 minutes. Sometimes it went a little bit further, just kind of with adjusting to this being a new program. And I think too, our participants were very engaged, loved utilizing the chat. And so sometimes it was kind of allowing those opportunities to connect and communicate with each other while also staying on task, which I think is pretty par for the course with 8 to 12-year-olds, right? And then also too, we did our best to get consistent survey results. Majority of our participants attended 3 or more sessions, but for those participants that weren't there for the final session when we were doing our post-survey testing, it was a little bit harder for us to get that completion, and so our data wasn't a complete set of data. And then moving on, and just kind of lessons learned, we learned from that first cohort to the second one that decreasing the age gap really kind of helped us to refine the content, even just from a maturity level. Like an 8-year-old to a 12-year-old is such a huge difference, and really trying to be mindful of that. And also too, just allowing kids with CF to connect virtually with kids that are their age, like going through the same transitions, going to middle school, all of those things, and really just being able to provide that same time real lived experience. We learned that we probably need to assign someone to help with IT in the future. And then we also got great feedback about kids liking to break out into smaller groups. With our cohorts being 15 participants, we tried to really have a great representation of our, just making sure everyone was able to talk if they were interested. But I think there definitely is a lot of need and interest in communicating and connecting. And so I think finding that balance for future programming. All right, and so kind of moving forward to future opportunities, just like Maddie said, we really love a pun at Primary Children's. And so we have a program coming up. It's actually starting this next Wednesday. It's called YETI, and the acronym is Young Adults Engaging in Treatment Independently. So we've got a new mascot. And this program is targeting kids that are 13 to 15-year-olds. So kind of prior to starting to receive that CF RISE education through clinic, we've been able to more readily enroll via clinic. It's really nice because I think these programs allowed us to build rapport and build relationships. And so we have been able to kind of really enroll, encourage, really pump it up. And so we're really excited to see. And our kind of future opportunities are we're really trying to ensure equity amongst enrollment in our clinic as well. Our CF Center serves 325 kids, variety of mutations, ETI eligible, and then also kids that aren't eligible for modulators. So just kind of really trying to make sure that we're representative of that population. All right, so did we goat your attention, Yeti? So thank you all so much. We're really excited to share this information. We just love to thank our center director, Dr. Asfor, for his support of this project. Our parent partners, Natalie Hinks and Jen Hepworth. Jen's in the audience, and she's awesome and has been such a huge, great feedback, super just passionate. Sorry, I'm like losing my words. So passionate and really just a valuable member of our team. So we loved having you. We love to thank the awesome kids with CF that were a part of our pilot programs. They eagerly participated. They rolled with the punches with our, our IT issues and really provided great feedback. And I think it's been cool to see them share with younger patients about these programs in the hopes that they're sustainable and we're able to keep them going and hopefully have them be kind of a part of our CF lifespan at primaries. And then to all of you as well, we know we're right smack dab in the middle of conference. So thank you for being here and thank you for being so attentive.
Thank you so much. Again, any questions, please come up to the microphone. What has been your proudest moment doing this project?
I think for me, I split my time, so I'm in clinic 50% of the time, and then I'm just general inpatient 50% of the time. But I think it's been so cool to see that secondary buy-in. Kids are excited to share the ways that they're exercising, or they'll tell us about the protein balls that they've been making at home. And I think just to see that engagement and community, and also just to see us providers as people outside of clinic, I think treatment burden is so real, and I think this has been a really cool opportunity for celebrating all the awesome things our kids are doing.
Yeah, I would agree with that. I would say that when kids have come to clinic after doing the program, they've had great feedback for us, and it's fun to see the things that they've started to work on and improvements that they've made, and some of the recipes that they've liked that we've shared with them that they've been able to make at home has been fun.
Well, thank you for a great presentation. My question is, how do you deal with the infection control issues of having all these kids together?
It is actually virtually led. So they are all at home virtual on the computer.
Oh,
yes.
okay.
Yep.
Okay,
Yep.
I was about to, I was okay.
Yes.
Yesterday, I'm sorry. I feel like I keep getting way too close. There was a presentation yesterday, and one of the RTs, and I can't remember what center she's from, she had shared that I think they're looking at those infection prevention recommendations. And from what I've heard and read and seen, we unfortunately won't be able to do that anytime soon and potentially never. But I think virtual has been a really great platform, and it's been really cool to hear about families that have been able to connect after the program. So hopefully this is really just kind of planting the seed for those relationships for kids these ages.
Yeah, and that was from Lisa Morrison, who works for the CF Trust on the guidelines for infection control, which won't be changing.
What time of the day and what days did you do the virtual program?
Yeah, we did them Wednesdays at 4:30 p.m. So after school and hopefully before they're eating dinner or going to sports.
Just thinking about, first of all, I love all your QI stuff, but thinking about your buy-in from hospital administration for the time allowance and whatnot. Did you all bill for education? Was it done through your EMR platform and you were able to do any billing, or is that something that wasn't possible?
So, for our clinic specifically, like when patients come to clinic, it's kind of one bulk fee. And so with this type of programming, unfortunately, we weren't able to bill, I think across disciplines, like virtual billing is like so limited and not approved. So this was really kind of like a complimentary option, right? And I think we were hopeful that it would promote improved clinic outcomes and attendance and those things. But yeah, it's definitely something that we've talked about. We've been really lucky to have a dietitian who's got a lot of QI experience. And for some of the newer members of the team, it's a really great reminder, right? In terms of sustainability, you have to have the funding. I think for all of us, we have a certain amount of time that is like dedicated and attributed to like QI work and documentation and those things. And so I think that flexible time has really been like our opportunity to work on these things. But our primary funding, and we actually just presented for like, for future programs, was coming from a grant that was like outside of CF resources at our center specifically. Yeah.
Thank you. Did you notice any improvements in weight, lung function metrics?
I'd say we haven't like tracked that data, but I think it's something that we could track in the future and see if there are any improvements. I think we've been told great things, but we haven't really tracked any of that data.
Yeah, and I think just as like a secondary, that would be such a great secondary project for us. I think our initial focus is really just on that health literacy piece. So I think that would be a great like moving forward like project for sure.
This has been quite a QI project, but for anyone who hasn't done a QI project, what advice would you give to someone for starting one?
Find someone who knows QI well.
The blind leading the blind.
100%. I think if there's something that you hear at clinic that you're passionate about, I think it really is feasible. I think our center, like we really lean on each other. Like it's honestly been so fun for us. And so I think if there's passion, there's a way, but 100% with an asterisk, like find someone that knows QI. So.
Your passion definitely comes across, but thank you very much. Is there any more questions before we finish up? Nope, you're free to. Oh, come on through.
Yes. So I just love all this project and not so much for, the literacy is very important, but it just have these kids get together and know that they're not alone. I think the sociological part of it is very important and sometimes is neglected. So I really loved that.
Thank you.
Yeah, thank you so much for that feedback. And one of our social workers is in the audience, and I know she wasn't represented up here, but there was such a great focus on self-care and managing stress and all those things, which I think we're seeing like with all of the highly effective modulator research, like anxiety and depression are still so very real. And I think having connection and community and opportunities to manage that are so important. So that was a big part of our program.
Well, thank you so much. Well, next up we've got Angela.
Thank you.
She's got it.
Can you hear me okay? Great. It's a pleasure to be selected and present today on my work. This is really focused on looking at balance and mobility disorders in patients with cystic fibrosis. These are my disclosures and funding sources. I have to thank CFF and also the National Institutes of Health for supporting this research over the last decade. So for all of you that are familiar with walking and standing, you'd know that postural stability is extremely important for our overall balance and mobility function. In order to have postural stability, you need to have a coordinated function of sensory, neural, and the musculoskeletal systems working together. So what happens when you have a breakdown of these systems? You also have a huge reduction in your overall quality of life. Like I think about myself, I have twins. I couldn't imagine not being able to go to the gym, to have time away from them, but also to run with them, to be able to do your day-to-day activities. And so a reduction of balance and mobility not only impacts that part of your quality of life, but it can also have a huge impact on your overall emotional health and well-being. So as patients with cystic fibrosis are aging, we need to consider this. They're living longer, and so preserving these functions are critically important also to reduce injuries as well as the risk of falls. So why would we think that patients with CF are at risk for balance and mobility problems? Many of you have probably been coming to NACFC for years or study this yourself, or you're in physical therapy or occupational therapy, but we know that CF is a whole person disease. So having the CFTR mutation can have direct and indirect consequences on a patient with CF. And because of this, we think that some of these processes can actually impact their overall balance and mobility function. What we know in the literature, there's really only one evidence-based study to show that patients with cystic fibrosis, when you do a full comprehensive test battery for vestibular function, 79% have shown some type of vestibular loss. And just briefly, I am an audiologist, full disclaimer, not a physical therapist. So I apologize if I'm not using physical therapy speak through my talk, but as an audiologist, we're really concerned about balance deficits because of these consequences. And so my lab for about the last 10 years has studied the impacts of potentially ototoxic therapies such as intravenous aminoglycosides on hearing in patients with CF. And we very much neglected as a field what is happening to the vestibular system. So this is one study that's extremely important, and having a 79% prevalence is alarming in these patients, and obviously it shows the need for future research. We also know that most of the work in this area has showed reduced exercise tolerance due to lung disease, which can lead to inactivity and fatigue. There are numerous studies that have shown musculoskeletal problems, which can lead to joint stiffness and pain, leading to risk of falling. And finally, pancreatic insufficiencies can lead to malabsorption of fat-soluble vitamins. This ultimately can lead to muscle weakness, ataxia, neuropathy. So collectively, we would think that all of these deficits would probably cause some type of day-to-day issue. What we don't know is that CFTR is expressed in the brain and it's expressed in the cerebellum, and we really don't know what CFTR does or how that might impact balance. So this really leads me to the current study aims. This was funded by NIH NCATS. And what we were looking at is if wearable sensor data can actually identify differences in patients with cystic fibrosis that are treated with intravenous aminoglycosides, and we compared that data to normative healthy control published data. Finally, what we're really interested in is looking at the mechanisms that are contributing to these balance deficits in patients with CF. And we'd like to examine how these relate to overall clinical balance performance. So in our methods, we had what we considered a standard clinical test protocol, and with the help of several physical therapists at OHSU, they taught me quite a bit about what you actually do on the day-to-day in terms of your walking and balance assessments. We used the functional gait assessment, which was manually scored as a clinical standard, and we also used the modified clinical test of sensory interaction on balance for our manually scored clinical standard on balance. We had 2 patient-reported outcomes, a dizziness handicap inventory to gauge subjective symptoms from patients to determine if they actually perceived an issue, and also a patient-reported outcome that was developed by myself and other clinical hearing scientists that are interested in ototoxicity, and this focuses on ototoxicity-related symptoms. The dynamic balance test is actually fairly novel. It's a super complicated type of posturography, which I'll go into a bit later, but we had a subgroup of our patients actually conduct this testing. And finally, our wearable sensor approach was using a instrumented M-sit-sib and also just a standard 2-minute walk and 6-minute walk test. For those of you that are not familiar with the FGA, I'll just briefly show you, these are the 10 walking task conditions. And in condition 1, for example, it's gait level surface. All that means is that a patient is walking on firm ground at their normal brisk pace for about 20 feet and they stop at the end. So these walking tasks have a series of complexities to them, and the ones that we were really focused on at the time were those that emphasize vestibular contributions. That would be the FGA 3, 4, and 5. Because those actually require some type of head turn. And with the vestibular system, if you're turning your head to the right or left, up and down, you're actually emphasizing vestibular input to maintain your stability. So this is an example of, it's a resident working in my lab. She's a neurotologist who is showing us how the FGA 3 test is conducted.
that. Stop.
Not an ideal space. She could hit the door, but she didn't. And but it's a good practice environment. So you probably heard the examiner. There's always an examiner with the patient who's instructing and watching the patient to ensure that they're not falling during the task and they're providing guidance. The FGA is manually scored, so the observer is also scoring how that patient did for each of these tasks with a maximum of 30 points, and then a lower score shows more deficit. This is one of my favorite tasks. You may have heard of the Romberg. It's the M-SITSID. And we conduct this task in 4 different conditions. The first is on a firm ground with your eyes open, and the second is with your eyes closed. The third condition is actually standing on foam with your eyes open, and the fourth condition is with your eyes closed. And I just want to briefly explain how important, even though it seems like a simple task, it really does task 3 important sensory systems for your overall balance. So we're looking at proprioceptive, we're looking at visual impact, and also vestibular impact. So in your first condition with the eyes open, firm surface, you need your proprioceptive input with your feet on the ground to tell you that you're actually standing firm. And it helps you maintain your stability. Eyes open is obviously the visual component. When we pull away that firm ground and have a patient standing on foam, it's actually taking away the proprioceptive input, and it's requiring more input of vestibular, more vestibular input to conduct the task. So for the manual scoring piece on this also, patients had to stand in each of these conditions for 30 seconds. An examiner judged how long they were standing, and if they met the 30 seconds, they received a full score. Finally, for our last clinical component were the patient-reported outcomes. So as I mentioned, we use the DHI, which is a validated test to capture more information about their overall just day-to-day quality of life related to balance, if they have concerns with dizziness and if they have concerns with just day-to-day activities. And this was ungraded on a scale from 0 to 100, and it also has some subscales that we considered. And finally, OXPRO not being a validated scale, it was really targeted on a Likert scale, looking at ototoxicity-related symptoms that include hearing imbalance, as well as tinnitus. So finally, this brings me to more the novel component. Now, kinematics, if you've heard of them, they're not really novel in the sense that they've been published in other clinical populations with movement disorders. But they're novel in the fact that they're not being used clinically still. And I think that they're a highly valuable tool. So in the Parkinson's disease population, we have a phenomenal physical therapist who is the co-director of the Balance Disorders Lab at OHSU. And she's performed a series of studies in patients with Parkinson's as well as MS and TBI. And she's actually validated these sensors as an objective way to look at the quality of overall motion. In that data, she's shown that kinematics or wearable sensor data can show differences, subtle differences that you might not see doing a standard clinical subjective assessment. So this is an example of turning duration. So if I ask a patient to walk a certain number of steps and then just turn around and come back naturally, the data with the wearable sensors is actually showing increased duration. So it takes patients with mild Parkinson's disease longer to turn, and even more if they have severe Parkinson's disease. And these are deficits that were not evident in this population on the common clinical scales. So we did similar tasks with patients with CF. This is our first finding of the mobility clinical standard using the FGA. So this is non-instrumented without the wearable sensors. And what we're showing here to the left are the actual tasks that were completed for the FGA that I showed earlier. Data on normal age-matched healthy controls, also data on patients with cystic fibrosis and our overall p-values using a Welch's t-test to look at significant differences. And what you see highlighted in gray are the actual tasks that showed differences, which is the FGA-1. I highlighted that in the beginning because it's just a standard walking task. You're just asking them to walk normally for 20 feet. And patients with CF are walking actually slower than patients without CF. The FGA-7 is the narrow base of support. And I hate to call it the drunk test, but everybody knows what you do. You kind of go heel to toe and heel to toe as they have their hands over their shoulders. And they're walking 20 feet. And they also show deficits in that task compared to the healthy controls. And finally, when you look at the manual scoring, the overall total score for the FGA was lower in patients with cystic fibrosis. In the balanced clinical standard for the manual scored MCITSIB and all of those 4 conditions, every patient that we tested, and again, we're working with adults, was able to stand for 30 seconds, except for one in the hardest condition, condition 4. So we did not see any differences between patients with CF and healthy controls in this manually scored task. And finally, I think this is, as an audiologist and a person that's really interested in improving quality of life based on symptom report, I'm a huge advocate of PROS in any type of research and clinical protocol. We were surprised that the majority of our patients did not report deficits. So for the DHI, 69% of our patients with adults said that they did not have real concerns with their day-to-day dizziness or balance. We showed 23% had mild deficits and 8% had severe handicaps. The OXPRO had a similar trend where the majority showed no real deficit, and there was a notable percentage that had some mild degree, but the majority of patients did not really have complaints. And now we're looking at our novel wearable sensor kinematic data. So patients aren't necessarily coming in reporting balance deficits, but we're seeing it on the wearable sensors, just like they were showing in these other clinical populations with movement disorders. So these box and whisker plots essentially are showing normative data for healthy controls versus the CF. And kinematics, if anyone's familiar with that, when you're doing a motion analysis, you get about 1,000 different parameters that are related to that person's motion. And so what we did is we selected the ones with the largest effect size that we knew would really show group differences, and that's what we're seeing here. So patients were showing overall a slower gait speed, and that was consistent with the instrumented data. Their turn velocity was slower. Again, asking someone to just turn after they're walking back and forth was slower for CF. Their stride length was shorter. And then in addition, double support is a really interesting one because double support just means how well they're using the 2 feet together. And patients with CF showed subtle signs of shuffling, kind of like you would see more severe in mobility deficit in patients with movement issues like Parkinson's. They had increased double support. So next what we did is we actually tried to make this clinically meaningful to the clinicians that work on the care team, respiratory therapists, physical therapists that are doing the 6-minute walk test. It's actually used as a validated measure for lung transplantation candidacy. And so we're still collecting data on this, but we had obtained data from 8 patients with cystic fibrosis, 4 healthy controls. And when we looked at the descriptives initially, we were surprised the trends were actually similar to our well-powered 2-minute walk test. So we had patients walk for 6 minutes. We also did the standard endurance metrics. We looked at their heart rate, respiratory rate, the Borg scale, looked at dyspnea, and their total distance in steps in this task. And what was interesting is that our patients were very healthy. They had normal across the board with the ATS guidelines in terms of each of those endurance metrics. Even their total number of steps were the same as the healthy controls, but we were still seeing the separation in just the objective sensors. So the instrumented 6-minute walk test is showing similar trends to the 2-minute walk. We also think that this is novel evidence in CF supporting that clinical measures of endurance alone may not be sufficient. We may need more direct measures of overall balance and mobility. And that we also suggest that there's patterns that are obviously different in patients, especially during walking tasks, that may impact distance, which is critical for patients as they develop more severe lung disease and they become candidates using these validated assessments. So finally, just paying attention to time, I wanted to highlight this figure for a couple of reasons. So what we did here is we looked at the relationship between what we call RMS sway acceleration. So when you're standing on foam, you're standing on the firm surface, or the MCITSIB, it's the objective sensors telling you how much that person was swaying to try to maintain their center of mass and balance. So we looked at that and we correlated that to gait speed in the walking task. And we actually found a fairly strong negative correlation between patients walking more slowly and having increased sway. And so what this means is there may be some overlapping mechanisms between standing, balance, and walking that you typically don't see in the literature. They actually report in other populations, they don't really see these correlations. And so this also leads us to want to really look at the mechanism piece, because we're curious if there's something unique to CF that is actually, that they're depending on these related mechanisms for. And so this control balance model was developed by Bob Baturka. He's a biomedical engineer over at OHSU in the VA, and he's probably the only person that really understands everything that went into the development. So I'll try to just briefly do a high-level overview of what these patients are going through during testing. As you can see here to your right, this looks like standard posturography if you actually have a vestibular clinic at your hospital and patients go through the full comprehensive battery. You have a patient that's harnessed in here standing on a moving floor. And what we do is we can change the visual surrounds, so you can change how much visual input is contributing to their dynamic balance posturography during different tasks. So the floor moves up and down and all around. And what we do is we take that data, process it, and it goes into this biomedical engineer world we call Bob's world. And it provides a series of sensory weights to each of the potential mechanisms that may contribute to how that person actually controlled their balance response. And so those weights, as you see to the left here, we're calling sensory integration. And those three main systems that are contributors are your vision, your vestib, and your proprioceptive. One key piece to this model is that we have this component called time delay, and time delay is really important for central nervous system input. What it means is when I'm about to fall and I have to have stimulation input from my musculoskeletal system up to my brain to say, quick, correct, ankle correct, right, to prevent yourself from falling. So we think that this time delay component is really coming from some part of the brain that's allowing these people to correct for prevention of falling. So finally, this is on a subgroup of the patients that I've showed with the kinematic data. This is looking specific to those weights that I talked about. What we pulled out were the vestibular weights. Because all of these patients were exposed to intravenous aminoglycosides, we assumed that their vestibular weights would be abnormal. So they would have deficits in the vestibular system to some degree. And we tested 7 patients with CF with exposure to aminoglycosides, 1 without. And just briefly, this is our normative range in green, and then the cutoff is also in this dotted green line. Everything above shows normal weighting. So just as a quick view, you see only 3 patients fell right below the normal line, which would indicate they have some type of peripheral deficit, but the majority didn't. The time delay component was really surprising in this data. All of our patients had increased time delay. And not all of these patients have, again, like symptom complaints of balance problems. But the time delay component in these other clinical populations has been highly related to central nervous system input. And interestingly, our data is looking like those patients that have mild TBI. So there's some mechanism, we're curious, like why are patients, not showing vestibular weights? It's very clear there's something else going on besides just vestibular deficits from these medications. So that kind of is a quick overview of the summary I just provided. So the interpretation here would be vestibular deficits may be subtle and or evidence of central compensation, and that the time delay component would suggest CNS processing deficits. But I think the key outcome I want everyone to take back here is that it's not just vestibular deficits that are creating any balance mobility problems we're seeing. And we used to think it was primarily from potentially ototoxic therapies. There may be other mechanisms at play causing these concerns that we're seeing in patients. So in conclusion, patients with CF who have a history of these aminoglycoside therapies have lower FGA total scores on the manual clinical balance test, as well as normal MSITSIB scores using the clinical standard when compared to healthy age-matched controls. And our kinematic data, the wearable sensor data, is showing that patients with CF are walking more slowly and cautiously than age-matched healthy controls, even though they're not really complaining about having balance problems. Finally, this would suggest that patients with CF may have other sensory and neural deficits than vestibular contributing to poor mobility and balance. So with that, I'd really like to acknowledge my lab. The pediatric and adult OHSU CF centers are phenomenal. Over the last decade, I've tested over 250 patients with their help to participate in these hearing imbalance studies. So I thank them, and some of them are sitting here today. And our funding sources, and for everyone for being here. So any questions?
Sorry, I thought she was coming up for a question. Thank you so much for
No
that
problem.
talk. Remind me, what was your age range in sort of the CF cohort at the moment?
Yeah, so we actually tested patients from 18 to 80. We did have a patient with CF that was 80 years old, but the mean age range was about 35 to 36. So 35, I think, for the healthy controls, and 36 in the CF range. Yeah.
And how many of them were over that 40 range? Just thinking of like our aging population really at the moment, and as they get older and more exposure to aminoglycosides, because I don't think we've ever considered that we'll be needing to give them like tobramycin for a lifetime really, but they're obviously going to have a lot of exposure to it a lot more now.
Yeah, and we really focus on patients with a history because we're not getting a lot of patients in the hospital on IV tobramycin anymore. So that the interest is, what are the long-term effects of this? And so we had about 30% of our cohort that was over the age of 40. And again, some of these patients haven't had any aminoglycoside therapies in 10 years. But we were still seeing these subtle changes. And so that's why, we're really interested in kind of pursuing, what do we do about this if we're noticing these changes, and what does it mean for early detection and maybe some early physical therapy? So.
Okay, I'll keep asking questions if no one's got how much is like sinus disease going to have an impact on this as well? Because that's obviously quite common in CF as well. Is that something you've ever looked into before, or can...
Yeah, we haven't looked into that. I think that's a really good question. We've done other studies looking at the effects of middle ear dysfunction associated with sinus disease in patients, and it's kind of a mixed review. We always thought that patients with CF, since they have increased sinus disease, would have increased middle ear problems, eustachian tube dysfunction. We're not necessarily seeing that. And we're not necessarily seeing patients with more fluid behind their eardrum. And so, but yeah, it's a good point. We haven't looked into that or associated it with this yet.
Okay, I'll keep going.
That's right,
yeah. Sorry if I was mistaken, but you say you work with PTs closely, and what if you have, what have they done on the back of all this at the moment? What's been sort of their management plan after finding this?
Yeah, that's a really good question. So we don't have physical therapists on our CF Care Center teams. The PTs that I work with actually were not familiar with CF at all, and I was able to recruit them to help write this grant that we're working on. And typically with physical therapy, so it's a combination. It's not the typical endurance physiotherapy you would have in CF, because they're working with patients that have movement disorders. So they're doing a lot more of like using the wearable sensors while they're doing physical therapy training, and then measuring how those sensors can track improvement over time. And that's ultimately what we'd like to see in CF. So their actual, I can't speak exactly to what their physical therapy care routine is in the Parkinson's disease and MS world. But yeah.
I just have a couple questions.
Mm-hmm.
How about modulator use? Like, when were you looking at this? I might have missed that when you were presenting it, like for the population. Are they on modulators now? Have they been, or is this just curious about?
Yeah, so we are looking at modulators. The majority of our patients are currently are on CFTR modulators. And that's why I was saying is in that 6-minute walk test instrumented data, it was very interesting that we had really, really healthy patients that have been on modulators for years, and we're still seeing these subtle deficits in the wearable sensors. So we need to stratify for patients on and off modulators, as well as our goal is to look at patients who've never had an aminoglycoside to see what's the impact of just CFTR, without the drug exposure.
Yeah. I was going to say, because I'm a pediatric therapist,
Mm-hmm.
and I do feel like some of this stuff manifests when you're older. But we were very much looking into vestibular stuff. We were invested in and seeing some odd,
Mm-hmm.
not really strictly peripheral type of things, patterns but once modulators hit, we are not getting the complaints and things in our population. But I will mention that one of our therapists that we were consulting, who is very well known and respected in the vestibular world, he was questioning if there was a central process going on and wondering about the CFTR just because some of the symptoms weren't fitting a traditional peripheral pattern. So I think that's interesting that you also brought that up.
Yeah, that's exactly what we're thinking. That, as I called the Bob posturography weighting test, we were shocked to see that patients didn't have these abnormal vestibular weights, and they've had a lot of these patients were older CF patients who had a ton of immunoglycosides. And so the vestibular system's complex in the sense that on the hearing end, when you have hearing loss, there's nothing to compensate for it. But when you have damage to the inner ear vestibular portion, you actually have central compensation. So sometimes patients have an initial insult to the ear from the medication, for example, and then they get better because the brain's compensating, so the cerebellar and other input. And so that's what we found fascinating is that what's going on with this time delay piece, because maybe if patients have CFTR mutation in these areas of the brain, we should be testing kids and looking to see if we still see these subtle deficits before they really have any type of health-related other CF complaints that affect the musculoskeletal and so forth.
Have you looked at hearing impact related to the vest noise?
Oh, related to the what?
Vest, use of vest.
Oh, that's such a good, well, we have not done that. Yeah, but I can tell you as an audience, like I can tell you a lot of our patients had come in back when we had quite a few on IVs and they'd come in with oxygen and immediately your low frequencies are going to be impacted. And the vest noise is similar, is that it has that kind of low frequency noise is very, very difficult to do an assessment. It's kind of like testing babies, their high physiologic noise. It's really hard to get a good assessment on this specific low pitch range for hearing. And the vest has that same kind of sound quality. So, but we haven't looked at it.
And then do you have balance assessment recommendations for inpatient pediatric patients to screen for balance deficits?
So anything, first, any possible screener. One thing that they do is if you want a bedside screener is the DVA test. And so your audiologists or your neurotologist should be able to provide some input on that test. The other is the Romberg. The Romberg is you can throw the foam on the ground and you get quite a bit of input on what's happening with vestibular versus proprioceptive and visual. So that's a really great bedside screener. That kids and adults can do pretty easily.
Well, thank you very much.
Thank you.
Thank you, Angela. Brill. And so we've just got one more talk to go, which is Lily.
Hello, my name is Lily Kostakevich. I am a respiratory therapist from Sutter Medical Center in Sacramento, California, and I am so excited to present to you our presentation called The Impact of Diaphragmatic Breathing Exercises on Lung Function in Children with Cystic Fibrosis. There are no relationships to disclose related to this presentation. Can you guys hear me? Okay, thank you. If we can take a moment and pause and think about what is the most nerve-wracking thing, or what our pediatric patients, what are they most worried about coming into our clinic? Aside from lab draws, what do you think they're most nervous or anxious about? PFTs, there, yes. So that's the hottest question coming into the clinic. They're like, what am I going to blow? Is it going to be higher? Is it going to be lower? What is my score? A lot of anticipation and pressure because it truly depends on their effort. So before I talk about specific techniques that we trialed, I want to share how we came up with this idea, or where this idea emerged from. So we have our monthly CF team meetings, and one of our topics, we were like, what are we going to do for QI? What can we do to improve patient care, patient processes? And we were thinking long and hard about this. And I remember we were dismissed, and it took some time. And long story short, one day I was singing. A little side note, I've been singing since I was 16. Singing is my passion. It's what I love to do. It's a part of me. And as I was singing, I'm going into the bridge of a song, and I had a realization where, as I was singing, I realized my ability to hit that note, it all relied and depended on the placement of my breath. If I did not take the correct breath in this technique, if I didn't take that technique correctly, I was not able to hit the note that I wanted to. The strength of my note, the longevity, even the overall tone of my note, it all relied on how I took my breath. And how do you think I took my breath? How do you think we're supposed to take a breath when singing? Diaphragmatic, right? And so that's when I had that realization, like, wait, what if we can use that same concept in singing and bring it into lung function? Is that going to increase our numbers? I'm just wondering, because when you sing, you need to take a diaphragmatic breath, or else you're not gonna sound pretty, to be honest. So lung function, unlike any other test in the clinic, it really depends, like I said, on patient effort. So it's really on us to motivate, to encourage, because we need our patients to do their personal best. So we use my vocal training background to help create some different enjoyable methods to help guide patients to perform their personal best during spirometry. I know we all know this, lung function. Why does lung function matter? We know the monitor disease progression, guide treatment decisions, evaluate response to therapy, antibiotics, predict outcomes. But for me as an RT, it's very important because it gives us a snapshot, a picture of how well therapy is really going on at home. Are they compliant? Are they being honest? If they're not doing the best, with the permission of our pulmonologists being on the modulator, are they really being super active? So for me, it's very important, and it gives me a snapshot when doing the PFT. So our clinic goal, we set a goal by introducing these diaphragmatic breathing techniques, we wanted to see the improvement of the percentage of FEV1 in 7 to 9-year-old CF patients by 3 to 5%. By using diaphragmatic breathing techniques or exercises. So 3 to 5% improvement, that's what we were looking for. And also to help teach correct spirometry technique at a young age. And I want to highlight and stress the importance, just like in singing, where technique is super important. If you are singing in front of, whether it's 10 people or hundreds or thousands of people, it all depends on your technique. And if they have poor technique, they will get a poor result. So we really our goal was to instill correct technique at a young age for accuracy. So when we think about taking a big, deep breath, what visually comes to mind first? A big puffy chest, right? Actually, that is not the right way to breathe if you want maximal lung capacity. They're more for like short bursts of air for like fight or flight, or you're nervous, you're anxious, you're running. That is not the way that you want to breathe, even though it's innate in us where you're like, take a big deep breath. You see the chest move. You don't want to do that. You actually want to be in a more of a relaxed state. And I know I've been hearing a lot of diaphragmatic belly breathing. So I really want to explain it to you, because sometimes we can name certain things, but I want you guys to understand and even practice on yourself so you can truly see the difference and feel the difference. So when we're diaphragmatic breathing, we're engaging the diaphragm. Okay, cool definition, but what does that really mean? So even here, you can see in the picture, the upper chest breathing, all the chest is expanding. Belly breathing, obviously the abdomen increases, but I want you to visualize and see how that works. So when you take a breath using your diaphragm contracts and it moves downward. When it moves down, this creates more space here in the chest cavity and allows the lungs to fully expand. And when the diaphragm contracts and as it's moving down, the abdomen expands. And when it moves down, not only is the chest, the lungs expanding on the sides, it's also deeper. So you have better gas exchange. You're able to draw in more air, and you have better gas exchange. And when you breathe out, your diaphragm glides on up and pushes that air out. And as a result, your belly will fall inward. So the two techniques that we trialed in our office was, number one, the most utilized was hand on belly, and the second one was supine book. So the first hand on belly, the patients were in a standing position, and the RT would place one hand on their chest and one hand on their belly. And as the patient inhales, when the RT would instruct 1, 2, 3, take a big deep breath, if done correctly, when the patient inhales, the RT's hand pushes outwards as the abdomen expands, and making sure that the hand on the top did not move to ensure that they are not chest breathing. And the second one that we used was supine book. We didn't use it, it wasn't as successful as hand on belly, but it still, like my patients say, came in clutch. In a lying position, I would ask our patient to lay down on the exam table in supine position, and we would place a few books on their belly, not too heavy. And when instructed, okay, we're and one hand on the chest, and we would say, okay, take a big deep breath. And when done correctly, you would, as the abdomen expands, it would cause the books to push upwards so the patient can see and feel that they're using the diaphragmatic technique correctly. So, okay, I explained this, so let's try it out. It's not that easy because we are older and we have a way of breathing. We're used to it. So I want you to relax. Stay seated, and I want you to place one hand on your chest and one hand on your belly. And I want you to first, before you take a breath, I want you to kind of tell your brain, I'm going to breathe in with my belly. Sounds weird, right? So when I say take a big deep breath, you're going to make sure that you don't take it up here. You're going to take it down here. You're going to take a big deep breath and feel like, my vocal teacher would say, feel like you're breathing in with your toes, like think downward. And when you take that breath, make sure that your stomach or your belly is expanding. And that's how you know you're doing it right. It's okay. It's going to take a few times. You might do the chest breathing. It's okay. You still get a pass. So let's try this. 1, 2, 3. Big deep breath. Hold and blow out. Your stomach should fall inward. Okay? Let's do that one more time. I'm pretty sure like 50% of y'all breathe with your chest. But it's okay, we're gonna do it again. So, 1, 2, 3, big deep breath. Feel your stomach expand, hold it, and I want you to push out a good 5, 6 seconds, blow out. All the way. So now you know how to perform correctly, and now y'all can sing. No, I'm kidding. So the methods that we use, so how did it look like? So we would do a baseline spirometry. So the patient would blow just using their regular technique. No instruction, just 2 little breaths, 1 big deep breath, and blow out. Then we would practice one of the 2 techniques, sometimes 2 of the techniques, because it's for some kids, it's hard concept to grasp. And we would do that and then perform a spirometry using the technique. And then we would do another one using the technique to solidify it. So our one thing I wanted to, oh, actually, sorry. Yes, results. So that was how we did it, and our results. So after one clinic visit, after implementing these techniques, our FEV1 increased from 87.68% to 89.93%, and our FVC increased from 88.58 to 94.33%, which was good. But if you look at multiple clinic visits, our FEV1 increased from 83.28% to 113.2%, and our FVC increased from 88.4 to 92.97%. You can see the difference, right? And I want to stress on why we see that difference is because technique, like a skill, it takes time, it takes practice. When performed correctly, just like I said, if you take your breath the right way, I mean, there's other factors that sometimes you can, hit a flat note. But when you take your breath correctly, you will sound beautiful and you can sing that note and sustain that note. And same thing with PFTs. If you perform it correctly, your FEV1 and FVC will increase. And our outcomes is that we now are integrating these techniques into care for all of our patients that are eligible and are able to perform these techniques. And that is all. Thank you. Any questions?
Hi. I had kind of more of a comment than a question, but I love that book method. I actually use like an ankle weight. I'm a physical therapist. I use an ankle weight sometimes with some of my, I'm mostly adults, so not kids, but with some of my advanced lung disease patients to get them to really like have that tactile feedback, kind of in that like supine hook lying position, but just like a spread out ankle weight. And they love it. They love having like something to push up against.
Yeah.
So that kind of made me think of it, and I feel like feeling that against them is probably really helpful. Just to
that visual
and
and
like
that
kind of
feeling.
like that they're pushing against something, kind of like lifting a weight but with your diaphragm. So thank you.
Yeah, thank you.
Hi, Jackie from Children's Hospital Philadelphia. Physical therapist, great presentation.
Thank you.
I was curious if when you guys practiced those techniques first before doing the PFTs, did it affect your flow from a clinic perspective? Our RTs do PFTs and PTs do like the airway clearance in our clinic, and I would love to pair with our RTs prior to PFTs to help our patients that are having trouble with technique, especially even our older kids that are having trouble. But I am curious if you had any pushback from a flow, since, everything is about efficiency and getting the patients in, getting the patients out. So just seeing if you had any barriers in that perspective.
No barriers, thankfully. We have an awesome team, and they were super excited when I presented this. And so it was the same visit. We don't have PTs at our clinic, but it was the same visit. So it was just, for them, it's just like, hey, we're going to do your PFT. It wasn't like, I would tell them, hey guys, I might take an extra 5 to 10 minutes because we have to go over the exercises, and it takes time. So other than that, I would say the appointment probably took no more than 5 to 10 minutes, because I can also see from, I nannied for 10 years too, and I'm oldest of 7. So I can tell, like, after 1 or 2 or 3 times, they're not gonna get it. And I would just stop it at that and just move on. So no barriers. Thank you.
Nice job, Lily.
Thank you.
I'm also thinking, would you consider collaborating with your mental health social worker team? Because when you do the diaphragmatic breathing, it also helps reduce anxiety and depression scores. So I'm wondering about maybe that would be another step.
to take?
So I actually, this is what happens when you're nervous, you forget to mention a few things. So we actually, as part of our outcomes, we killed 2 birds with one stone. I didn't even know that our social worker, Margot, was already practicing diaphragmatic breathing techniques with the kids in reducing stress and anxiety. So it was like, woo, we got 2 birds with one stone. So that was awesome. So thank you. Yeah, that's great feedback.
What was the age range for implementing the trials?
What was the age range? It was 7 to 9. 7 to 9-year-olds. And should I say why? We chose 7 to 9 because 5 to 6, we're just getting familiar with the PFT machine, and there's a difference in comprehension and just between 5 to 6 and 7 to 8. So we wanted to do it as early as possible, but not so early where it's pointless. But the younger that we would teach these patients, the better results we would get.
Lily, which technique did you find most effective?
Hands on belly. And I actually have a chart right here. So we had 81 patients that were successful in hand on belly, 11 supine book. So I would always start with hand on belly, and the supine book, there was 11, 5 where I had to integrate both techniques, and 23, it's where they just couldn't grasp it, the concept of the technique.
More of a comment, but I also engaged the parents to do the hands-on technique and to put a hand on top of theirs and just to tap on the belly on the hand when they're inhaling to bring it up.
Oh, okay.
And then light pressure when they're exhaling, or excuse me, light pressure when they're inhaling on the chest to remind it not to come
Oh,
up.
no.
So
Okay.
more of a inhale as a tap and push, and exhale, then our
Got it.
hands can release on that. And I find it kind of helps the kids, like, oh, if I forget when I get home, mom or dad can help me because they're going to remember that.
They
as
can
well.
remind them.
And I'm always hesitant to put my hands on the patient, so I never know who's comfortable with it. Or
Yeah,
not.
I always ask.
Yes, oh, definitely. But it kind of helps to engage the parents as well, I feel.
Yes.
So,
Thank you. Great feedback.
thanks for your talk today.
Thank you.
Lily, at what point of the clinic do you do your spirometry? Because our patients will attend clinic, we literally sit them down and go, right, now blow. But I wonder whether we have to think about at the point of their clinic, like a time, we just need to give them time to just relax and not be so anxious about the visit and not be the first thing that we do with them.
Yeah, we had dinner with a few different clinics, and I realized our clinic flow is a little bit different. So I actually go in last. And that's the way that our clinic runs, because since we've had COVID, some of the team members aren't comfortable with the RT going first. So I go in last, and that's what we've been doing. So it's working.
And I guess that's really hard, isn't it? Because actually, I guess your peak flow testing, you probably rely so much on that as a result to then what you're going to do with that patient. Are they well? So it's hard if it's going to be left, if that's going to inform your medics, but also you do need it probably fairly on in your consultation. But I don't know if it's the right thing to do it like literally get in and go.
Yeah. Give them time to warm up. It's been working out great. So.
Well. Brilliant. So that concludes our session. Thank you so much. Just a reminder. Okay, let's stop. A reminder, all these presentations are posters, so you can get to everyone if there was a question that you had, but you just don't want to come up. But please find them all in the poster hall as well. But thank you so much for coming.